Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. And this is our final one for 2024. Our guest speaker tonight, and we're very fortunate and very excited to hear her, is Dr. Ashley Tucker, who's a University of Houston College of Optometry graduate, where she also completed a corneal and contact lens residency at the University of Houston. And she received extensive training and experience in the diagnosis and management of corneal diseases in complex contact lens fittings and myopia management, focused primarily on orthokeratology. She's a partner at Bel Air Family Eye Care and the Contact Lens Institute of Houston, which is a private practice in Houston, Texas area, where she primarily cares for patients in need of specialty contact lenses and myopia management. She's also a visiting assistant professor at the University of Houston's College of Optometry. She also serves as the public education chair for the Scleral Lens Education Society, and she's a regular columnist for Contact Lens Spectrum, Optometry Times, and Review of Myopia Management. So with that, please, a warm OEC virtual welcome to Dr. Ashley Tucker. Please take it away.
Thank you so much. So I'm really excited to share this lecture with you. It's kind of a fun way to end the year. It's kind of, it'll be a fast and furious just review of a whole bunch of anterior segment and refractive conditions. So here we go. Here are all of my disclosures. They have all been mitigated. This will be the format. So I will present a patient case. Then in most cases, we'll review the diagnosed condition. Then I'll present the traditional treatment options. And then at some of these, this juncture point, we'll be having a polling question asking you what you will do. And then I will discuss the details of my treatment option, which may or may not be in alignment with what you do. All right, so let's get started. So case number one is entitled The Repeat Offender. He was a 45-year-old Caucasian male. He woke up this particular morning, with a lot of pain, 6 out of 10, positive foreign body sensation, positive watering, and he's also photophobic. This has occurred several times in the last 2 years after his 2-year-old little son scratched him in the eye. So this patient was new to my office for this particular visit. He was only in town for a week for a work conference. He knows exactly what's happening. He knows exactly how to treat it, but he was in hopes of finding a doctor that would do something a little bit different because he's getting irritated with this process happening over and over again. So this is what his eye looks like. So we have some positive and negative staining. We have a little bit of loose epithelium over to the right of this picture. So what is the diagnosis? I think we all know this is an RCE, otherwise known as a recurrent corneal erosion. So what exactly is an RCE? So we have to look at this as a clinical syndrome. This isn't really a one-off situation. This is something that patients deal with. It's a syndrome that's characterized by inadequate epithelial basement membrane adhesions, resulting in repeat episodes of corneal epithelial defects. So if you look at the picture on the right, we have this very disrupted band of epithelial cells. They are trying to grow back together, but something's just not right. They won't grow back together properly. And that's what's part of this syndrome. They'll grow kind of partially, but then they'll never get back to where they should be, which is on the left, the normal cornea. So RC is very commonly associated with prior trauma, but one thing that we tend to forget that it's also correlated with underlying corneal disease like corneal dystrophy, specifically epithelial basement membrane dystrophy. So about half of all patients that have RCEs probably had a prior injury, but some of them do have some sort of anterior segment or anterior corneal dystrophy, excuse me. The highest rates of RCE occur in patients that also have dry eye, diabetes, blepharitis, MGD, and ocular rosacea. So there are several factors. So just because a patient had an injury or just because they have some sort of corneal dystrophy doesn't mean they're going to end up with an RCE. These sorts of things have to also be part of the picture. So dry eye, diabetes, MGD, blepharitis. And if they were tested, they would also show an increased level of certain enzymes such as matrix metalloproteinases that will dissolve the underlying basement membrane. So what are our treatment goals for these patients? We all have the same goals. So we want to facilitate rapid reepithelialization. We want to relieve their pain. And mainly for this patient specifically, we want to prevent reoccurrence. So what are the traditional treatment options? So to facilitate rapid reepithelialization, typically patients are prescribed artificial tears, ointment at night. Some patients that deal with this recurrently over and over and over, they have serum tears on board. If this is an initial incident right after the RCE. Sometimes a topical antibiotic might be warranted because we're not really sure what's going on. But for those patients that we truly know these are recurrent issues, a topical antibiotic is a little bit overkill, but it wouldn't be wrong to do it, but you can. A bandage contact lens, of course, that will help the upper eyelid from interacting with the RCE, so it will help reepithelialization. Pain relief, I rarely have to do topical NSAIDs or oral NSAIDs for these patients. Usually a BCL takes care of it. But for those patients that need something to take the edge off, absolutely. And then preventing recurrence is key here. So the two main treatments for this are debridement and polishing, and then anterior stromal puncture. So corneal debridement, depending on where you're from, some people say debridement, but here in the South, we say debridement, also known as a superficial keratotomy. This particular procedure will reduce reoccurrences by about 20%. And all we need to do is remove that loose or weak epithelium with forceps or a surgical sponge, and then just take a diamond burr and just kind of smooth out that irregular surface. Now that insult will look a lot worse than it did prior to you doing this, but you're essentially creating a nice smooth surface in hopes of those epithelial cells adhering to the basement membrane appropriately. And then again, this can reduce recurrence by about 20%. And I do want to mention that we need to be doing this procedure when the RCE is active. You don't want to do it later on after the patient is already healed. Another procedure we can look at is an anterior stromal puncture. The success rate for reoccurrence is pretty high. So if we do this, 75 to 80% of patients will not have a reoccurrence. Again, this needs to be an active RCE situation, and you're essentially taking a 20 to 27 gauge needle and creating 50% depth perpendicular little punctures into the anterior stroma. And what we're doing is creating epithelial plugs that will hopefully allow that area to just tighten up and not have that RCE again. So I think it's time for a poll question.
Let me launch that poll question.
Thank you. So I essentially want to know what you guys would do at this point. Would you do one of these things that I just mentioned, or are you thinking outside the box and perhaps want to do something different?
So what is your treatment of choice for this patient? Is it artificial tears / ointment? Is it a bandage contact lens, debridement / polishing, anterior stromal puncture, or is it E, none of the above? And if it's E, none of the above, maybe you would put that comment in the chat box and we'll look for it.
And I will say, depending on the patient, depending on the scenario, I would do any of these things. It's just in this particular case, I may or may not have done some of this.
So Ashley, at some point, remind me when the webinar is over, I'll send you a video, someone having PRK done, and how hard the epithelium is, and then how easy the epithelium comes off when they have RCE. It goes well for when we do REC talks in the anterior segment. I have no problem if you use them.
Thank you.
All right, looks like the polling question is coming in well. I'm going to display it. We have 25% that are going to use artificial tears and ointment. The winner is bandage contact lens BCL at 52%, debridement and polishing at 18%, anterior stromal puncture is 1%, and then we have 4 people that are going to do none of the above, and maybe potentially, Joe, is there anything that has been put into the chat box?
Oh yeah, a couple of people have put in things that they're going to combine modalities, but a few people mentioned topical steroid as well as amniotic membrane.
All right, let's see.
Also, doxycycline 50 milligrams by mouth per day for a month.
Okay. Again, all great choices. I just chose something a little bit different. I'm in alignment with one person, I think. So I chose an amniotic membrane for this patient. And I'll tell you why. He had already done artificial tears, ointment. He actually was a patient that had serum tears. He had been on a round of antibiotics multiple times with his previous doctor. None of his doctors had done anterior stromal puncture or the debridement. So I am a big believer in amniotic membranes, and I'll tell you all about amniotic membranes if you're not too familiar, because this is something that can change a patient's life. It can change the course of what these RCEs do. They have a really negative impact on patients. So, and I later found out that this particular patient had diabetes. So he was probably going to have a lifetime of recurrent erosions. All right, so what did I do? I debrided that cornea right away. It was in an active state while he was in town for a conference. I applied a cryopreserved amniotic membrane. I did a lid tarsorrhaphy because he was very uncomfortable with the particular membrane that I chose. You can see here, it has a silicone ring. So I just taped his lid shut, no big deal, with a little bit of surgical tape. I gave him an oral NSAID as needed, not for the RCE, but for the foreign body sensation that he was experiencing from the membrane. And then in this case, I did give him a prophylactic antibiotic. I just simply gave him Polytrim. I didn't think there was any risk of infection. I wasn't worried about that at all, but he was only in town for a few days and I wanted to hit him hard and make sure I had every basis covered. And I just did that out of an abundance of caution. So this is just still a picture of day one. I don't have pictures progressively throughout the treatment plan, unfortunately, but follow up day one, the RC appeared about 50% healed. Most of the membrane was still intact. And then by day two, it was 100% healed. And the center of the membrane had dissolved a bit. So I removed the cryopreserved membrane and then I have him on maintenance therapy, preservative-free artificial tears every day, several times, and a preservative-free ointment at night. And he has not had a recurrence in over 2 years. And I know this because after we did this, he was so excited that he was seeing some progress with his RCEs because he was getting them every 3 to 4 months. And now he comes to see me every time he's in town for that conference. So I've been following him over a few years. And with this membrane and then just maintenance therapy, he's in really good shape. So what exactly is an amniotic membrane? How does this come about? So as you all know, the placenta is an organ that develops in the uterus of a female during pregnancy, and the placenta consists of 2 layers, the outer chorion, which is vascular and in contact with the uterine wall, and the amnion, which is avascular and it lies inner or inside to the chorion. It's in contact with the amniotic fluid. If you've never seen an amniotic tissue, here we are. I'll get rid of that if you are weak on your stomach. And then what I found unbelievable, with this piece of tissue, up to 30 grafts can be prepared with 1 placenta. So pretty remarkable what can happen with these membranes. And just so everyone knows, those membranes are acquired only from women who have cesarean sections. It would never happen. We would never be able to get a membrane from a vaginal delivery just because of the risk of infection. So that piece of information can be helpful when explaining what an amniotic membrane is to patients because they get a little weirded out by it. So common amniotic membrane uses: corneal ulcers. I love using them for corneal ulcers, corneal abrasions, dry eye, and exposure keratopathy, of course, RCEs, filamentary keratitis, and herpes keratitis. I like using them for central large ulcers because they can prevent scarring. And then corneal abrasions, I like to use them for huge corneal abrasions like this particular patient to prevent the consequence of potentially getting an RCE. So some of the mechanisms of action: mechanical, of course. It acts like a really fancy BCL. It promotes reepithelialization. It can be antifibrotic. It can prevent scarring, anti-inflammatory, anti-angiogenic, which means preventing neovascularization. And then lastly, they can be antimicrobial. So there's actually no antibiotics in an amniotic membrane, but it more so acts as a barrier for the bacteria. So the bacteria can't get from the lid into the corneal insult because the membrane creates an actual barrier. So we needed both of these things, mechanical and promotion of reepithelialization, for this particular patient. So how are these preserved, if you're wondering? There's 2 different ways to preserve an amniotic membrane: dehydration and then cryopreservation. I chose a cryopreserved membrane. The picture on the left is the dehydrated membrane, and the picture on the right is a cryopreserved membrane. The cryopreserved membrane can go onto the eye just like that. The dehydrated membrane has to be coupled with a contact lens, so basically a BCL. So with cryopreservation, it's basically slow rate freezing. Dehydration is using a vacuum with low temperature heat. Because heat is utilized with the dehydrated membrane, cryopreservation is generally thought to preserve the tissue structural integrity and biological properties. So the cryopreserved membrane is the one that has been studied more. There's more just proof that this is effective in managing these corneal insults than the dehydrated membrane. Both of them work well. It's just the cryopreserved membrane seems to be a little bit more effective in some of these more complicated cases. So for dehydrated membranes, they are only approved by the FDA for wound coverage. Cryopreserved membranes are a Class II medical device that are approved for both wound coverage and healing. For dehydrated membranes, the shelf life is pretty long, 2 to 5 years. Cryopreserved, 3 months to 2 years. Dehydrated membranes are less expensive to us as a practitioner. Cryopreserved, a bit more expensive. Dehydrated, they can be stored just on a shelf, very easy to store. Really, you don't need anything special. Cryopreserved does require freezing or refrigeration. Dehydrated membranes, because they have to be coupled with a bandaged contact lens, you really just treat them like a BCL. You put them on like a BCL, you take them off like a BCL. Cryopreserved membranes are a little bit more involved, and I'll talk about that in a second. The practitioner cost ranges from $125 to $900 per amniotic membrane. There's a big range there, but regardless, typically the cryopreserved membranes are more expensive than the dehydrated membrane. So tools needed for application and removal: anesthetic drops, saline solution, blunt tip or groove forceps, and then eye patching materials or surgical tape if you want to. If you want to do that tape torsorrhaphy like I did with my patient. I never wore gloves prior to COVID when putting on a membrane, but COVID changed everything. So now I consider wearing a glove whenever I'm handling these membranes. If it is frozen in your freezer in the kitchen somewhere, if you want to use it, just make sure you take it out for about 5 minutes and allow it to thaw. The biggest issue with this is to remember that it is preserved in a glycerol solution, and it's completely clear. And because it's clear, you think it's totally safe to put on the eye. But if that glycerol solution gets on the patient, it will burn them like crazy. So make sure you rinse the front and the back off profusely before you put it onto the patient's eyes. I usually use an entire bottle of Purulens or preservative-free saline just to ensure that I get all of that glycerol solution off. So how do we put it on? Apply a topical anesthetic. You hold the patient's upper lid, ask the patient to look down, and then while you're holding the membrane, you just slide it underneath the upper eyelid, then have the patient look straight, pull the lower eyelid over the bottom of the membrane, and then check for centration on the slit lamp, just like this. You can actually apply fluorescein to the membrane just like you would to the naked eye, and you can also check IOP with the membrane on if you need to. Follow-up schedule, you are basically just following up to see whether the membrane has dissolved. For very, very severe cases, like a really 4++ SBK situation or an infectious ulcer, that a membrane will dissolve in 24 hours. But for milder cases, it can take up to a week. The FDA requires that an amniotic membrane cannot stay on the eye for more than 29 days. If it's on the eye for almost a month, it probably shouldn't be on the eye anyway. So more than likely, the membrane will resolve within a week. At the time of dissolution, we need to remove it, apply topical anesthesia again, pull the lower eyelid down, lift the lower edge of the membrane with your blunt forceps, ask the patient to look down, pull the upper lid up, and then just slide it from the upper fornix. You always want to have the patient look down because you could scratch the eye and abrade the eye on the way out. This is not my patient. This is just a picture from BioTissue's website. This is just an example of a lid torsorrhaphy. It's just clear surgical tape that just allows the patient to be more comfortable because they really, the membrane itself doesn't bother them at all. It is that silicone ring that bothers them. So just having the lid taped shut will allow them to be so much more comfortable. This is, we won't go too much into this, but I absolutely believe that RCE treatment, amniotic membranes, should be thought of as potential first-line therapy. We do have a lot of great options that do work, but there's nothing wrong with putting an amniotic membrane on these types of patients because you can really do them some good by preventing reoccurrence. There was a study done back in 2013 by the journal, it was published in the Journal of Clinical and Experimental Ophthalmology. They looked at 11 eyes of 9 patients. After debridement and placement of that cryopreserved membrane, all of them reepithelialized within 4 to 7 days. And then after about 14 months, only 1 eye reoccurred and required repeat treatment. Most everyone got a nice smooth ocular surface, visual acuity improved. So I do want to challenge everyone to think about amniotic membranes for these RCE patients because some of them truly are suffering. They kind of live on edge, not knowing how they're going to wake up. So doing this could really change the trajectory of their life. Here's the fun part, reimbursement. This was back in 2022. For the life of me, I could not find updated information, but it's still about this. It's actually, I think, a little bit more. So for the CPT code of 65778, which is the placement of an amniotic membrane on the ocular surface without sutures, the physician in office reimbursement is about $1,400. Now, let's say you're a physician and you are doing this in a hospital, you're only going to get about $53. But that's only because if you're not doing it in your own office, they are not going to reimburse you for the membrane itself. They'll only reimburse you 53 buckaroos for putting the membrane on. So most of us won't have any problem with this. We're doing it in our private offices or in an office of some kind, and you should be able to get reimbursed about this amount. These are all of the diagnosis codes that can be utilized. I'm pretty sure last I checked, this was an all-inclusive list, but it may not be. I don't want you to hold my feet to the fire on this, but there are a lot of codes that can be used here. Some of them are kind of weird, like ARCUS. I'm not sure why we do amniotic membrane for ARCUS, but there are a lot of ones that absolutely make perfect sense, like all the different ulcers, punctate keratitis, dry eye, those sorts of things. All right, any questions about case number 1?
Well, actually, before you go on, Ashley, I want to throw in a clinical pearl.
Sure.
I just finished, I mean, when I say just finished, I mean, as of yesterday, a case, malpractice case defending optometrists involving your topic here, recurrent corneal erosion.
Okay.
And your patient, had pain upon awakening. And this is what we've all learned in first grade of optometry school to think of: pain while opening eye, recurrent corneal erosion. Well, I'm going to caution everybody to be a little bit more exact in the history. The question becomes, did you have pain when you awoke, or did the pain wake you up? The first, the former is recurrent corneal erosion. The latter is a corneal infection. And that was the issue here. It was either an erosion that got infected, or possibly, or probably more likely, was a misdiagnosed infection. So if the pain upon awakening, if the pain wakes you up, it means the eye's been closed, it's moist, warm, good environment, inflammation, the organism is proliferating. So if the pain wakes you up, that's different than when you woke up and you had pain. So for the audience, please all be very careful in your history and ferret that out. Yeah. It's a difference between an RCE and an actual infection.
Yeah, that's a great point. Just
a couple points I'll point out will be, I made a couple notes here, is that someone commented that they had a recurrent corneal erosion patient that for a few months kept changing their alarm clock or setting their alarm clock to not tear open, and slowly over time they kind of healed themselves. One thing that I have in the lecture when I present, it's something I came up with at the office, and maybe Joe, being a good writer, can help me maybe write an article up on it, or at least a case on it. Is I have probably now one patient passed away. I have 3 patients. I used to have 4 that didn't want the amniotic membrane, didn't want to go for PTK treatment, didn't want to do stromal puncture, but they were willing to wear what I call a nocturnal bandage contact lens. I fit them with a focus night and day at night so that they can, when do they tear open? As Joe said, when they wake up. So if I can put it in as a retainer, I train them to wear it at night. They sleep in it, get up in the morning, kind of start their day. They take it out, put it in the solution, and then, they wear reversal instead of during the day, as a monthly lens, I guess, planned replacement, and then toss it. They buy the lenses, and I've had 3 patients right now that have done that for several years. A nocturnal bandage contact lens. Another thing I'd like to point out to the audience is that this is a naturopathic way. You heard me kind of starting to fold in these naturopathic, supplements and vital tears, amniotic membranes are what's more naturopathic. This isn't a allopathic or opposites cure like antibiotics and steroids and glaucoma meds. This is, what's more natural than taking a placenta a part of the amnion, part of the placenta, the amnion, and using those natural biologics to heal. So if you're thinking of getting into holistic and naturopathic medicine and you're already doing it, amniotic membranes, you're already doing it. If you're thinking about doing more of it, do amniotic membranes. And the last thing I'll point out is that if you read the package inserts on some of the dehydrated where it's contraindicated, the dehydrated are contraindicated on infectious keratitis, where the cryopreserve is not. One is wound covering, that's your dehydrated, and wound healing is your cryopreserve. Actually, the FDA does differentiate those out there. So, good review of amniotic membranes, Ashley, and thanks for bringing that to the forefront of your first case tonight, because I have about 20 in a row where I have used a cryopreserved amniotic membrane to treat these recurrent corneal erosions.
Awesome. All right, we're going to switch gears a little bit. So case number 2, this patient is the distressed dad. That is not a typo there. I really wanted to spell it like that. So he's a 46-year-old Asian male, reports blurry vision for the last several years, has become just progressively worse. So his symptoms are horrible at night. So he's a dad of multiple kids that are in lots of sports, and he's having to drive them back and forth in this dark, tiny country road at night, and it's becoming an issue. Glasses nor contact lenses have proven to be helpful. He had PRK 10 years prior. He's not in any pain. He's not in any discomfort. He just wants to see better. I mean, he is truly desperate to see better. His uncorrected vision is 20/60 right eye, 20/70 left. I can improve his vision with a refraction, no improvement with pinhole, but he is just unhappy. So that's a 20/40 2 to 3 line improvement in acuity. I was pretty excited about that, but he wasn't. He was very just about that acuity improvement. So this is what his cornea looks like. So I probably should have looked at his cornea before I refracted him. I did not. I just started refracting. And this is what I see behind the slit lamp. So what is the diagnosis? This is granular corneal dystrophy type 1. So I did not know this right off the bat, even though I lecture on corneal dystrophies all the time. There are so many of them, and a lot of them look alike. So when I get a cornea case like this, I really go to my notes. I go to a textbook that I have about corneal dystrophies just to put all the pieces together, because there's so many of them. And again, they kind of get a little similar after a while. So what are corneal dystrophies just in general? So they are typically bilateral. They typically onset very early in life. They're very symmetric. They're almost always hereditary. They're slowly progressive. They're not associated with any systemic condition, no inflammatory processes like neovascularization, and they typically affect the central cornea early in life and then progress out to the peripheral cornea later. We all learned about corneal dystrophies in school, and they were probably classified a little bit differently. This is a fairly new classification system. The way I learned the classification system was basically epithelial, stromal, endothelial, and then somewhere in between. But now we have a recategorization because we have a whole line of dystrophies that are linked to this TGFBI gene, so the transforming growth factor beta induced gene. These are all of the dystrophies that fall within this category, and these are the ones that kind of look alike. So Reese-Buchler, Steele-Binky, Lattice, granular type 1, and granular type 2. So the TGFBI dystrophies, they refer to a group of inherited corneal dystrophies that are all caused by mutations in this TGFBI gene. So this particular gene instructs the cornea to make a protein called keratoepithelium. A protein I had never heard of before, but this particular protein, when there's a defect in this protein, it creates these amyloid deposits all over the cornea. So that's where we get those breadcrumb-like deposits that we see in the granular dystrophies. So there's 2 different types, type 1 and type 2, few different key differences. So granular type 1 onsets early, granular type 2 onsets later childhood, early adulthood. Type 1 has those very characteristic demarcated lesions that resemble snowflakes or breadcrumbs. And then type 2 really looks like a combination of lattice and granular type 1. And I'll show you pictures here in a second. So our patient in this case had granular type 1. But if you remember, this patient had PRK 10 years ago. So how was a patient like this able to get PRK? Were they not screened properly? What happened? Because if their cornea was assessed, you would think someone would not have done any sort of refractive surgery on this patient, but somehow he flew under the radar. So this is what granular dystrophy type 1 looks like in other patients. This is kind of the early presentation of type 1. And this is what can happen later in life. This can be very visually debilitating for patients. But this is how all different types of patients with granular type 1 can look. So I really think my patient was in the A, maybe even B category when he got the PRK. It looked very subclinical. It easily could have been missed. I'm just assuming that he just wasn't screened properly. But now we have a situation where the patient is post-refractive surgery with a very irregular cornea and a dystrophy. This is type 2. Remember, type 2 looks like lattice, which has those lattice lines, and then a combination of lattice plus the breadcrumbs that you see in type 1. So what are some of the typical symptoms? Glare, which is my patient had that, photophobia, absolutely, and visual acuity, usually not affected until the 4th decade for most patients. Again, he's fitting the bill perfectly. And then with all of the corneal dystrophies, especially the anterior corneal dystrophies, RCEs are very common. So remember that just because you have a patient with RCE, they may not have had that inciting incident. Because I've had these cases where patients like, yeah, no, I never got scratched with a fingernail, nothing ever scratched me in the eye. So then you need to be looking at their cornea and seeing if they have an underlying corneal dystrophy. So traditional treatment options for these patients: artificial tears, treatment for RCE if they needed, PTK, phototherapeutic keratectomy, or a corneal transplant. So lubricating drops are first-line therapy when patients have a foreign body sensation. This particular patient was not in any pain. He wasn't even in any discomfort. So, but there are patients that do have that foreign body sensation. Lubricating drops are certainly appropriate. You might want to prescribe a preservative-free drop if they're using them very frequently, and potentially an ointment at night. PTK for those patients that have really, really dense, just scattered deposits all over their cornea. So it's essentially an excimer laser that is used to ablate 5 to 10 microns of Bowman's after mechanical debridement of the overlying corneal epithelium. So the top is a patient that has type 1 granular dystrophy, and that is prior to the PTK, and then just below that picture is post-PTK. So you can imagine this patient's visual acuity will dramatically improve after this procedure is done. And then for those patients that have this kind of presentation, they need a corneal transplant. So the corneal transplant that would be appropriate for this particular type of patient is a deep anterior lamellar keratoplasty. And this is what it looks like post-operatively. So a lamellar graft involves removing the epithelium, Bowman's, and as much of the stroma as possible, but leaving decimase and the endothelium intact. Nothing is wrong with the posterior cornea. So we want to keep the posterior cornea intact, but remove the anterior cornea. This procedure is useful for dystrophies in which the anterior cornea is affected, but the posterior cornea is in normal health, which is definitely this type of patient. This is just a visual that goes along with that explanation that I just gave you. So a lamellar incision is made just anterior to decimase. That is the host tissue is removed, and then the donor tissue with that exact same amount of tissue, so epithelium, Bowman's, and stroma, is then attached to the host decimase and endothelium, and then the donor tissue is sutured on. All right, so next poll question. I think I'm asking you here, what would you do? Would you refer this patient out? Would you do something else? Tell me what you're thinking here.
Okay, the polling question is now open. What is your treatment choice for this patient? Artificial tears. Refer to an OMD for PTK. Refer to OMD for corneal transplant. Recommend spectacles/contacts. None of the above. Comment in the chat box. The polling answers are rolling.
Those answers are rolling in, Ashley. A question came in earlier about amniotic membranes. Are you treating patients with more than one membrane?
Yeah.
And if so, in what situation?
Yeah, so those infectious corneal ulcers, they will eat a membrane in a night. So yes, I will treat use as many amniotic membranes as I need to get the infection down, the epithelium closed, and in a place where I feel that the cornea is okay to move forward outside of the membrane. The really great thing about amniotic membranes is that there is no global period, so you can keep utilizing membranes, but you need to make sure that you are charting perfectly to show that this is warranted and that you're not abusing billing and coding for amniotic membranes.
And I'll add to that I prefer a cryopreserved amniotic membrane, and for various reasons. One is pentraxin 3 and the heavy chain hyaluronic acid, which don't get destroyed in the
Right.
in the dehydration process because it's cryopreserved. But they also have a plus, which means it's a double membrane, and I always keep one of those in my freezer just for those infectious, because the hotter the eye, I agree, it will burn through. There is a question in there. It says, curious how an amniotic membrane is indicated for, I think, low tension glaucoma and primary open angle.
I get that question a lot. It's really when a patient has a bleb that is irritated. That's the only reason why you would be using an amniotic membrane for glaucoma. It's not directly for glaucoma.
Yeah. And then if the eye is quiet, I would cautious using it, because remember, amniotic membranes promote healing, and you don't want to, scar down a trap that someone has worked so hard to get that fluid to leak out. So kind of be cautious when you have those blebs that are out there, those different types of trabs that are out there. So, someone asked, what's your favorite company? There's a bunch that make dehydrated. There's one that makes cryopreserved. I do keep a handful dehydrated in my practice, maybe for the dry eye-ish patient, but I like to go with the big hitter out there, because there are differences between dehydration and cryopreserved.
I'm
But
team cryopreserved 100%, and there's only one company that does it, so you guys can look that up.
Yeah. All right, let's take a look at the polling question. I think we probably got enough people weighing in here. We have 7% going with artificial tears. We've got referred to an OMD for PTK is 62%. That's your winner. We got 30% going for a corneal transplant, 1% recommending spectacles and contacts, and we have no one doing anything different.
Anything different. Okay. So we have to remember with this patient, yes, his cornea looks like this, but he's not in any pain. All he wants from me is to see better. He has told me that he's heard that I've done some pretty cool work with other patients. So here we are. So what I've decided to do with him is, if I can get my screen to go, is a scleral contact lens. So scleral contact lenses, you guys may have remembered in my biography, that's one of my major passions is specialty contact lenses, mainly sclerals. So I will utilize them as much as I possibly can to help patients. First things first, though, I need to look at his cornea. I need to see what was going on. So this is the topography of the right eye. This looks crazy, right? You can see these areas of irregularity. He's kind of flat centrally where that PRK probably, used to be, but we have this kind of surrounding area of steepening, so super irregular. The right looks bad. The left eye to me looks even worse. Just these geographic packages or pockets, of irregularity. So you can't expect to put glasses on this patient and for him to see his best. And really, soft contact lenses are just going to drape over these irregular patterns and not provide any improvement in vision. So I was really hopeful that a scleral contact lens could do its job and make this irregular surface see through a regular surface. And so it did. So I fit him with this particular lens, an oblate design. I'll talk about why here in a second. A scleral lens, both eyes. And you can see with these parameters, best corrected visual acuity was 20/20 -1 in the right, 20/20 -2 in the left. And with both eyes open, he was getting some letters on the 20/15 line. Now, I fast forwarded through the fit. This wasn't a one and done sort of scenario. I had to actually fit him, go through a few layers of troubleshooting, but we got him to a point where he was ecstatic. He got his life back. He regained freedom of being able to drive at night and feeling confident and driving his kids around in those dark, windy roads out in the country where he lives. I love doing anterior segment OCTs on my patients to demonstrate to them what's happening with the lens and for me to measure central sag, mid-peripheral sag, limbal sag. So if you're not familiar with looking at this, this is truly a cross-section down the middle of the patient's eye. So the top two bands, that's the contact lens. The middle is the clearance. And then that area with gray with those little hyperreflective spots, that is the patient's cornea. So those are all of the granules that are in this patient's cornea. And you can see we've created a nice smooth surface for this patient to see of. This is the right eye, and then this one is the left. Not as dramatic with the granules, but still a really great visual of what we're trying to accomplish here. And this is what the lens looks like on the eye with blue light. You can see the granules through this contact lens, but again, the patient is ecstatic here. So how do sclerals work? Why do they work in this particular scenario? So sclerals are designed to land on the sclera. That's why they're called sclerals. And they vault and clear the cornea and the limbus. So we're not in contact with the corneal surface at all. So that's why they're so comfortable. And that's why they create a great visual for the patient. The improved vision, why this happens is because there's a tear layer underneath the scleral lens that neutralizes all the corneal irregularities. And if fit right, it more often than not can neutralize all the irregular astigmatism. So it essentially creates a smooth ocular surface for the patient to view out of. Improved comfort, they're typically even more comfortable than soft contact lenses because they land on the sclera. They don't touch the cornea at all. So again, fit properly, the patient should be feeling very comfortable in this lens. And then it can protect the ocular surface. So this is fantastic for patients that have ocular surface disease. And it can prevent the eye from desiccating, and it can allow some healing as well. So if you recall, this patient has a dystrophy that could potentially have RCEs in the future. So this is a double whammy. We're improving his vision, and we're hopefully preventing that cornea from desiccating and causing a recurrent corneal erosion in the future. So let's go through the 1, 2, 3, 4 step of fitting scleral lenses. We won't get too much into the nitty gritty, but just enough for you to get your feet wet. So the first step is to choose a diagnostic lens and choose your design of choice. So really you're choosing between an oblate design and a prolate design, which we'll go over, and a diameter. I'm in Texas. I like to go big or go home. We say that all the time here in Texas. So I typically tend to fit bigger. I start with my 17 millimeter. The fitting set that I have has a 16 as well, but I just like to go 17. I usually find that when I'm troubleshooting, the main thing I'm having to do is go bigger. So I just go bigger from the get-go. There are times when a smaller lens is warranted, but if I had to choose, I would default to the larger diameter. You're going to fit the lens with sodium fluorescein until you get a good diagnostic fit. You want to get good apical clearance, limbal clearance, and you want to land on the sclera. Then we over refract and put all that together in order. So how do we decide if we're going to choose a prolate or an oblate design? So oblate is usually for post-LASIK, post-refractive surgery, post-PRK. Some post-graft patients do fall in the oblate, but I have many post-graft patients that fall into the prolate. So you really, if you have a topographer, need to take a topography and look at the overall pattern. It can go either way with post-graft patients, but almost always post-LASIK, post-PRK will need an oblate. And then prolate, 99% of the time, normal corneas and then keratoconus patients will need prolate. This patient, this is just a reminder of our patient here, very irregular, but if you had to choose, oblate would be the better of the two because we are flat centrally. We do have some mid-peripheral steepening and then kind of the same on the left. Very irregular, but I went with oblate and then that ended up working out well for this patient. Now, when we look at central clearance, we have a lens on the eye. We can look at it in diffuse light, which is what you see on the left. We should see a nice lawn of green with our fluorescein. We don't want to see any areas of bearing or touch. This picture on the left is perfect. And then we want to scan over the cornea with an optic section. And you can see here on the picture on the right that you can compare a few things that can be very helpful. So the first arrow to the far left, that little grainy spot, that is the actual thickness. That's the lens itself. This particular lens is 350 microns. That green band is the fluorescein underneath the lens, and then the grainy to the right is the cornea. So typically, we want the tear lens to be about the thickness of the contact lens. So we're getting about a 1-to-1 ratio here, which is perfect to start with. But what's ideal? This varies from manufacturer to manufacturer, from patient to patient, from doctor to doctor. But if you have to choose, moderate clearance is where you should be. So 100 to 250 microns after settling. This patient is right at 176. This is just an example patient, but that's appropriate. Another patient may do a little better with 100 microns. Another patient may do a little better with 250 microns. It really does vary, but I would recommend living in that moderate 100 to 250 microns after settling. I love this graphic because this really can happen. So if you do not measure clearance after the lens has settled, you may overestimate how much clearance you actually have. So the picture on the left is immediately after you put the lens in. The picture on the right is about 30 minutes to an hour. And then the picture in the middle is 30 minutes to an hour later. And the picture on the far right is after the patient has worn the lens all day long. And what we see here is apical touch. Where we started, we have plenty clearance. Now, this is a very dramatic settling. This does not happen for most patients, but this could happen. So it's important that you have your patients on, let's say, the follow-up visit, come after they've worn the lens for several hours, just so you can make sure that you're clearing after complete settling. But usually you lose about 100 microns of clearance from initial insertion to full settling. Again, this is a dramatic case, but it does happen. Once we've established central clearance, we definitely need to look at limbal clearance. That's important for patients, especially that have a corneal transplant. We want to protect those limbal stem cells. The amount appropriate the appropriate amount of limbal clearance is anywhere from 50 to 100 microns, which is what you see in this top picture. And in the bottom picture, we see limbal bearing, which is going to be very problematic as the patient continues to wear this lens. They will end up with neovascularization at some point. I love looking at limbal clearance with an OCT. Not all of us have anterior segment OCT functionality in our offices, so you don't have to worry. These are the bells and whistles. If you have this, absolutely use it. But if you don't, you can look at limbal clearance with an optic section. So let's start on the far right. So that first band, that little teeny tiny band that we see, that's the fluorescein on top of the lens. Then going to the right, we have a black band, that is the lens. And then that green thicker band is the limbal clearance. So that's excessive. Then let's go to the far left. That's very limited clearance. And then right in the middle, we have a picture of optimal clearance. So if we don't have an OCT, just scanning over the limbus with an optic section can also be very helpful. Now we need to look at scleral alignment. What we want a scleral lens to look like is exactly with what a soft lens looks like. And when it comes to the scleral alignment, we don't want any blood vessels blanching, impinging, nor do we want edge lift. Edge lift is just as problematic as blanching or impingement. We want that lens to land on the sclera just like a soft lens does.
Hey, Ashley, before you get too far, could you just go back 2 slides when you were using your OCT?
Yep.
One clinical pearl that I want to point out. Oh, go one forward. I'm sorry.
One.
Right.
Forward.
Yep. Nope.
Not
The
that
one with the one more OCT. That. Okay. I guess go forward now.
Forward. Okay. Okay. Not that one. Not that one.
Not that one. Not that one. Next one. I think it's the next one right there.
Okay.
Is that, using kind of that OCT, this is kind of looking as if you were looking through the OCT. This is kind of like a slit lamp. But when you're using the OCT, this is not an OCT, but if you're going to use an OCT, and this is kind of the image that you see here, what will happen is the technician, to get those temporal ones in the previous slide now, if you go back one, if you as the technician is doing, if they have the patient look left or to the right, it will actually kind of jam that lens and not give you the best thing. So you kind of have to learn how to have the patient look straight ahead and get that nasal, temporal, superior, and inferior, would be to the audience that's out there trying to get these clearances right here. Make sure that the patient isn't looking to the temporal side to get the nasal, because that lens will not sit the way it is when it's sitting centrally. So little clinical pearl.
And that is so true, Greg. And this right here it takes some experience to be able to really look at this. I would really focus on looking at limbal clearance with diffuse blue light, because it's so easy to see in the top picture on the left, we're clearing the limbus. And in the bottom picture on the left, we have bearing on the limbus. So if nothing else, just look at it with diffuse light and you'll be able to appreciate whether or not you have decent limbal clearance. And if you're in doubt, when the patient comes back, have them take off the lens, stain the eye. If there's limbal staining, you are bearing on the limbus there, and you need to lift it off the limbus. All right, so let's look
Thank you for going back. Thank you.
Yes, of course. So let's look at some pictures of blanching versus impingement versus compression. I mean, we throw those terms around all the time, but what does that actually mean? So impingement is this top picture where the edge of the lens is digging into the sclera and it's really cutting off those conjunctival vessels. This, if you're trying to get fancy, this is called toe compression. Like if you think about a shoe, that the tip of the toe is kind of, we're on our tippy toes essentially. Now the next picture on the bottom left is blanching. That's heel compression, so that we're back on our heel and we are blanching further interior to the lens. And then the picture on the far right is a combination of impingement and blanching. So we have compression of the vessels at the edge and then a little bit interior to the lens. So all of these are bad, and all of these are, you need to fix this by adjusting the peripheral system or the haptics of the lens. That's a whole nother lecture, but at least tell the lab what you're seeing and they will be able to help you adjust this. This is edge lift, which is completely the opposite. So the edge of the lens is curled up or kicked up. You can see this in the picture on the left. We have some fluorescein that's just pooling right there. That's problematic. And in the picture on the right where the arrow is, you can actually see air there. You can see it's not touching the sclera at all. Patients will tell you this in a heartbeat. They'll tell you, hey doc, every single time I blink, I feel the lens up here, or I feel it over here. That's a clue. Go look in that spot and you'll probably see that the lens is lifting there. This is again utilizing the anterior segment OCT function. This is just looking at the edge of the lens. So the top picture is ideal. So that lens is just landing on the conjunctiva very nicely. The middle picture is too flat. The edge of that lens is starting to kick or curl up. And then the picture on the bottom is too steep. That the edge of that lens is going to be impinging those vessels there. And you can see the conjunctival tissue is starting to heap over the edge of the lens. That will leave a compression ring when the patient takes the lens off. And the eye will be really hot, irritated, hyperemic when the patient takes the lens off. Oh, that's it for that case. Any questions about scleral lenses, fitting, anything before we move on?
There was a question that came in. It says, why does a scleral lens help with RCE?
Okay, I love that. Because you are filling the lens with a fluid reservoir. So we're basically bathing the cornea in fluid all day. So like the patient are doing artificial tears, they're doing serum tears, ointment, all of that. This is just making all of that nourishment on the eye all day, every day. Of course, during waking hours, this is helpful, but not at night, but it's just nourishing the just fragile cornea throughout the day. Great question.
And then there is the Zen lens your go-to scleral? How many different design brands do you fit?
Okay, I've been fitting for several years now, and the Zen lens is my favorite, and I definitely talk to whoever wants to talk about it off camera. It's a fantastic lens for starters, for beginners, and then there's so many advanced features that you will kind of age into as you grow with the lens. But yes, it's a fantastic lens.
Are you doing any of the minis, scleral minis?
I don't do any mini sclerals at all.
Okay.
I only do full diameter.
Okay, I just got that fit set and it seemed to have worked pretty decent. I just
it's a good, they're 15.6, 16.4. Those are great. I just like bigger lenses.
You just like the bigger ones. You're from Texas. Hey.
Exactly. Exactly.
All right. We're caught up.
All right, great. So case number 3 is the terrible pterygium. So this is a 35-year-old Hispanic male. He was diagnosed with keratoconus at 13 years old. He had cross-linking in Mexico at 21 years old. So prior to when it was FDA approved here in the US, he got it done there. He's tried sclerals, but cannot wear them comfortably due to a very big pterygium on the left side. He has poor vision and current spectacles, but he just wants to wear contacts. He's 35, he's young, he's healthy. wants to wear contacts. That's just what he came to me begging for. Entering VA is not half bad. So right eye is 20/30, left eye 20/80, both eyes open 20/60. He's not interested in removing the pterygium. That will be the obvious thing to do, but that's just not something he wants to do. So this is what that pterygium looks like. Pretty vascularized, getting close to the visual axis. Just it's unsightly too. He's not excited about it, but he just wants to be able to see better. This is what his topography looks like. It's making his cornea extremely irregular. So let's talk about traditional options for keratoconus. So yeah, spectacles, maybe. Soft disposable toric contact lenses, maybe, but not really a great option for this particular patient. An RGP, a corneal RGP, potentially. We can make a smaller diameter that would maybe avoid the pterygium, possibly. A piggyback system, I kind of like the idea of that. So that's a soft lens with a corneal RGP sitting on top, potentially. And then a corneal transplant, typically in about 20% of patients is what we're looking for, a corneal transplant for patients that have keratoconus. But we have to remember, this patient, he just wants to see. There has to be a simpler option than surgery, hopefully. Some of the modern treatment options for keratoconus, scleral lenses. You guys know I love a good scleral lens. Hybrid lenses, if you don't dabble in hybrids, I really would recommend that you do. It is just a fancy piggyback system. It is designed as a piggyback. So it's in the center is an RGP, and then on the outside, the skirt is a soft lens. This could potentially work for this patient. And then intracorneal ring segments. So if you haven't heard of these are just silicone rings that are placed in the stroma, and essentially it will flatten out a steep surface to make contact lens fitting easier. And for some patients, it gives them a better uncorrected visual acuity. So that's an option for this patient. So what do y'all want to do?
So can you go over what a piggyback is? I know when I bring that up, people will come to me at the end and say, Doc, what is a piggyback? Well, what are you talking about? So while this is going on.
Yeah, so it's just using a soft lens, really any kind, really, really low power, or you can put power in it. It depends on what you want to do. But the concept is putting a soft lens on the ocular surface and then putting a corneal RGP on top. So essentially it helps with patients who have a big awareness of the RGP. That would be the only reason that I would ever fit a piggyback. Is there any reason why you would fit it other than that, Greg?
No, that's it. I just to explain that's, it's kind of the old, kind of an old way. I'm kind of, 29 years of doing this, kind of the old guy. We were taught piggybacks back in the day.
Yeah, I was too.
Kind of put that, not all schools do it. I think maybe in the scleral, or in the cornea sections, they'll talk about it, or that becomes a little bit more of a technique that's out there. But putting that soft lens on, kind of giving that landing zone for that RGP to land on there is basically what it is. But I agree. I don't know the last time I did it because of the hybrids that are out there.
Yes.
Thank you.
You're welcome.
All right, let's see. We've got display this here. We have soft contact lens, 7%. Cornea RGP, 11%. And then the hybrid was 70. And then, I spelled surgery wrong. I have surgery, but I think people figured it out. Refer to OMD for surgery was 2 responses or 4%. And then looks like some people are going to put some answers in the chat box then, because that was 7%. So
got it. All right.
Joe, anything in the chat box?
Only thing is refer to a specialty fitter.
There you go.
And something else is quad specific scleral.
Well, those are all great choices. What I decided to do with this patient was an impression-based scleral design. So these are my absolute favorite type of scleral lenses to fit. I'll talk all about them, but I want to go through some of the options you guys said. So a corneal RGP, there is nothing wrong with this. So this is a patient of mine with a teeny tiny pterygium that actually does really well with a corneal RGP. You just have to fit it small enough that it doesn't interact with the pterygium. It will, and it's going to stain just like this. A solution potentially would be a piggyback system here, a soft lens to prevent that lens from eating up the pterygium from time to time, but that's a totally reasonable option. A scleral with a microvault, I'll talk about that. A scleral with a notch, scan-based scleral designs, and then of course that impression-based that I'm getting ready to talk about. But I do think a hybrid here is totally reasonable. I don't know why I didn't list it. I fit hybrids all the time, but a hybrid lens for sure is fine. So microvault versus a notch. So a notch is essentially a scleral lens that we have cut a portion of the lens out to just go around that pterygium. It's pretty fantastic. It works great. It is a pain in the you know what to create, but once you create it, it works great. It can be used for all types of peripheral obstructions. Here's a filtering bleb. The one on top is a pterygium, and this is another bleb here. So again, notches are great, but again, a little cumbersome to fit. Microvaulting, similar thought process, but it's creating a ripple. So basically a channel in the lens that just sits over the pterygium. That's what it looks like. Again, both of these are pretty cumbersome to fit and get just right. But once you get it, it's pretty amazing. And you can see the picture right here in the middle that microvault is sitting over the pterygium. The eye is just red because it's red. It has nothing to do with the lens hurting the eye, but that's just a very vascularized pterygium that this patient can wear this lens all day long very comfortably. Nowadays, we have these scleral topographers and profilometers. I don't actually have one in my practice. I either fit diagnostically or I fit impression-based lenses, but these are game changers. If you have access to this, the advantages of a scan-based design are numerous. It can take a scan of the entire ocular surface and then create a custom lens for the patient. Less need to create complicated modifications. It saves time for the practitioner and the patient. It is a really great option. But what I like to do are impression-based lenses. So you're essentially making an ocular mold, sending that mold to a lab. They have a 3D scanner, which creates a 3D image like this, and they 3D print me a lens for my patients. It's essentially a fingerprint of the eye, an ocular surface impression. It's a unique ocular prosthetic. It is ideal for patients like you see on the bottom with very extreme geometry that has failed in other lens options. It's also great for patients that just want the best of the best. I have lots of patients that come from far and wide to get the best and the best of the best, and this is it. Really, you can't really get any more custom than this particular design. The impression process, it's painless, even though I look like I'm being tortured here. I had done this 7 or 8 times by this point that the picture was taken for our training session, but it takes 3 to 5 minutes, 1 to 2 minutes for the mold itself to set up, and then 1 to 2 minutes on the eye. It captures precise curvatures of the entire ocular surface with a 1 to 2 micron accuracy. Comfortable and gentle, no anesthetic necessary at all. Some of the benefits here is that it's exceptionally stable because it's created like a glove. It fits the eye like a glove. So it's not going to move around because every little nuance of the ocular surface is accounted for. So of course, this is perfect for spheres, great for torics, excellent for decentered optics. Patients that have a decentered graft, we can decenter the optics right over their visual axis. Fantastic for multifocals. If you're like me, I really don't love fitting scleral bifocals unless it is done with an impression-based design. Otherwise, they can be time-consuming and tricky. We can also put optical prism in any direction in this particular lens, and then to come, we'll have higher order aberration correction. So this is what that lens looks like on this patient's eye. I mean, this is beautiful. I was so proud that this technology was able to accomplish this kind of lens design for the patient. He sees well, he sees 20/15 out of this lens, and he can wear it all waking hours comfortably. But here's the kicker. This bad boy is not inexpensive at all. So the device itself ranges from $1,000 to $2,500 for the device. And I'm calling it a device because they call it a device. They do not want it to be called a lens, this particular manufacturer. You must also consider the price of the impression. So we can talk about it off camera. I'm not sure if we can talk prices on, impressions, but the impression makes the lens considerably more expensive. And what I mean by the impression is taking the time and making the mold, because it's not a one and done. You have to do the molding a couple times in office. It takes about 30 to 45 minutes. And it takes skill and time. So there is a cost associated with that. You also have to factor in any remakes that you want to do, and then any add-ons like prism, multifocals, hydropeg, those sorts of things. So the price
if you want to chat a price price. We're
It's
not
okay.
sitting here tonight saying everyone out there should
Okay.
charge this price. We're not
Yeah.
price fixating. We're not doing any collusion. If you just
Okay.
want to throw an average price out
Sure.
there, what this would
Yep.
cost, then everyone gets scared about that, which I really like. But we're not sitting here, everyone out there listening, you got to charge this. So there's
Okay.
no collusion. So
Perfect. So the price on the impression is about $1,000. So there's a range here because there is a very technical lens that costs about $3,500 with the impression, and then there's a less expensive one that costs about $2,000. So that range of $2,000 to $3,500 per eye, it is encompassing the least complicated eye to the most complicated eye. And unfortunately, we don't get to decide that. We send the mold to the lab, and then they tell us which one is more appropriate for the patient. You can give a recommendation, but sometimes they'll tell you, well, you quoted the patient this lower one, but we need you to quote the patient the higher one. Unfortunately, there is no insurance coverage for this because, again, it is a device. It is not considered a scleral lens. So that is the impression-based technology that is available to all of us. Is there any questions about this one in particular?
Nothing in the chat box.
Okay. Fancy lens, not for everyone, but it can really, really save a lot of chair time because there's no fitting. You are making the mold, you spend time in the office creating the mold, and the lab does everything else. So look into it, ask me questions later about it if you're interested. All right, so let's move on to something a little bit different. So this one I have labeled the picky publicist. She's a 33-year-old Indian female. Obviously, she is a publicist. She's very, very unhappy with the appearance of her left eye. She's had this issue her entire life, but it's starting to become more bothersome to her now. She's out in the public a lot more. She sees herself on Zoom calls, and she's just annoyed. No relevant medical or ocular history. This is what she looks like. Quite lovely, but that left lid just bugs her. So the diagnosis, pretty obvious that it's not a bad case, but what we're dealing with here is just a mild ptosis of her left lid. So we all know what a ptosis is. It means drooping. It's when the upper eyelid droops, and it is typically called blepharoptosis or upper eyelid ptosis. Ptosis is present when the upper lid is lower than its normal anatomical position, typically 1 to 2 millimeters below the superior corneal scleral limbus. And there's two different types of ptosis: congenital and acquired. So congenital ptosis, just like it sounds like, it's most common in children. It's typically there at birth or develops within the first year of life. Approximately 75% of congenital ptosis is unilateral. And there are cases when ptosis can cause amblyopia, either from the lid itself occluding the pupil or from that lid causing amblyogenic astigmatism. But acquired ptosis is what we need to be concerned about. This patient has congenital ptosis. She does not have acquired ptosis. But if we didn't know that to be true, we really need to work through these categories and figure out if we're dealing with something that's purely cosmetic or if we're dealing with something that's a little bit more serious. So an aponeurotic ptosis, myogenic, neurogenic, mechanical, traumatic, those are all the different types of acquired ptoses. Aponeurotic is the one that we see all the time. It's the most common acquired ptosis. It's also called involutional ptosis. It is when there is dehiscence or disinsertion of the levator aponeurosis. This is not a muscle issue. This is a connective tissue issue. So essentially that tissue is just aging with the patient. Seen in older patients, it can be caused from trauma, from frequent eye rubbing. It can even be caused from prolonged RGP wear. And for those of us that have been practicing long enough and we've seen patients age with RGPs, we definitely see this. And we see this usually bilateral, but sometimes more asymmetric. And it can also actually happen after surgeries like cataract surgery as well. Anytime that the lid is manipulated, an aponeurotic ptosis can result.
Before you move on that slide,
yeah.
Can you maybe use your pointer there on the right eye and show show that lid line on that patient with your pointer there?
Oh, okay.
And if you can show that, because it will show up. And if not, there you go. And now do the right eye first, if you would. You can see that lid line right there. So she does have bilateral ptosis, but if you look at the lid fold, I guess maybe the lid fold where the aponeurosis is coming into the lid, right, a little bit down, a little bit lower, right there. There's the lid fold. This one is starting to pull away. That's where the muscle inserts into the tarsal plate and creates that lid line. And then if you go to the other eye, you don't see the lid line, or it's way up under there, the lid fold, and that's almost a total disinsertion. So that's one way you can tell, aperneurotic. Patient looks down, they still have, 11 or 12 millimeters of function, but you can see that asymmetric ptosis from that aperneurotic disinsertion of, from the tarsal plate, and you can just see it with the lid fold there. That's a great picture.
That is a great picture. Thank you. All right. Myogenic ptosis. This is a true muscle tissue. Before it was more of a connective tissue issue. This is true muscle. So it can be either acquired or congenital. It's due to dysgenesis of the levator muscle with fatty tissue found in place of skeletal muscle fibers. Can be unilateral or bilateral. Almost always these are found in patients that have more like muscle dystrophies and those sort of conditions. So most of the time, these are congenital. We do see them as acquired ptoses when patients develop these conditions over time. But again, this is a muscle issue, not a fatty tissue issue. Mechanical ptosis, just like it looks like in this picture, this is an abnormality of the lid that is caused by something that's weighing down or altering the lid function. So this could be from a tumor, a chalazion, a hordeolum, orbital fat prolapse. It can also happen from scarring from surgery, Stevens-Johnson syndrome, all different things. But usually the issue can be removed and the patient's lid goes back to normal. Traumatic ptosis just happens when the patient has had trauma to the eye. It can also happen when there's cranial nerve 3 damage, and this is caused by disinsertion of the levator muscle or damage to the levator muscle with scar formation. This is the one that we all are scared about. So neurogenic ptosis. These can be the first sign of a life-threatening issue. So we need to make sure that we're not disregarding these. I know none of us would, but I do want to review these a little bit. So third nerve palsy, Horner syndrome, and then myasthenia gravis. All three of these present with the ptosis, with other things as well. But the ptosis is the thing that the patient typically will report. And we just have to be careful. We don't want to disregard these. Some of these can be associated with fatal medical conditions. So let's go through them. So the third nerve cranial palsy, any degree of ptosis. Remember what we learned in school, this patient will typically present with an eye that's down and out. The eye cannot supraduct, it cannot infraduct, and it cannot adduct at all. So if the pupil is dilated, this is likely a compressive third nerve palsy. So we have to be thinking about something very serious. So if the pupil is involved, or the pain is, or if there's pain, or both, so pupil involvement and or pain, we have to assume that this is an aneurysm, and we need to send the patient out in order to figure out if this is truly the case. So we want to send them out to the ER typically for an MRA or CTA. If the pupil is dilated, again, it's likely a compressive third nerve palsy. If the pupil is not dilated, this is probably ischemic from hypertension and or diabetes. But the key here, if there's pupil involvement and or pain, the patient needs to be sent out. Okay, so that's third nerve palsy. Horner syndrome, we have that classic triad of ptosis, meiosis, and anhidrosis. If the patient has any neck pain or severe headache, we have to assume that this could be due to a carotid dissection, and the patient needs to be sent out for a carotid Doppler. Now, some of us may have epreclonidine in office. I certainly don't, but if you do, and you put a drop in, and the pupil dilates and it's no longer meiotic, then we can just assume that this is not as serious of a case. Or even if you have cocaine drops in your office, again, we typically don't. Usually with ptosis, meiosis, anhidrosis, we just assume that this could be a serious event and we send the patient out for further testing. And then myasthenia gravis, any degree of ptosis, it could be bilateral. The patient could have difficulty swallowing, speaking, or breathing. This would certainly indicate a myasthenic crisis. And again, this patient needs to be sent out. So all of these cases are very serious. I love this slide because it kind of just puts everything into one big graph for us and just lets us know that these things need to be taken very seriously. But again, my patient just had a congenital ptosis. None of this was in any part of her history at all, but we do need to be very aware that this could be a possibility. So how do you quantify ptosis? So a margin reflex distance, or MRD1, MRD2 is for the lower lid, MRD1 is for the upper lid. It's the distance in millimeters between the central portion of the upper eyelid margin and the pupillary reflex. So a normal MRD1 is 4 to 5 millimeters. The difference in the MRD1 between the normal and the ptotic eye is the amount of ptosis. So for the picture on the right, you see a 4 millimeter MRD1, and the picture on the left, you see a 2 millimeter MRD1. So that means that this patient has a 2 millimeter ptosis on the left side. So pseudotosis, this can happen. We see this all the time. It typically looks, it looks like a ptosis, but it's usually from dermatochalasis, brow hooding, brow ptosis, microphthalmus, endophthalmus, or phthisis bulbi. It also can look, when a patient has thyroid eye disease, a retracted lid can also make a patient look like they have ptosis on the opposite eye. So here are a few pictures. This is a patient with dermatochalasis that kind of makes the eye look ptotic, but you can just tell that that is fatty tissue and that's not actually the eyelid at all. This patient has a little bit of lid retraction in both eyes. Perhaps one eye is a little bit more retracted, making the opposite eye look like it is ptotic. This is an ophthalmos in a little baby. And then this lovely lady has brow hooding. So she has like more of a prominent eyebrow, which makes her potentially look like she has ptosis, but she does not. Treatment options for these sorts of ptosis patients are usually surgical. You probably all know where I'm going with this case, but for my patient that had a very mild, like maybe 2 millimeter ptosis, a surgical option was not what she was looking for. Blepharoplasties are fantastic for hooded eyelids, but ptosis correction is what the patient needs for actual ptosis. So you can see the difference. So the top pictures are patients that just have that fatty tissue that's starting to fall down due to gravity, and then a blepharoplasty is done. But the patient in the bottom has a lower lid that is kind of creeping over the visual axis, more so on the right than the left, and then ptosis correction would be appropriate for her. You know, I love a good scleral contact lens. This is really a great use of a contact lens. I would never put a patient in a scleral just to fix their ptosis. But if a patient needs a scleral lens and they also have a ptosis, which we find quite often, it will lift the eyelid to a more normal position. All right, so all of that serious talk, what do we do for this particular patient to help her with her ptosis?
All right, I have the polling question open, and it says A, monitor, refer for surgical ptosis repair, fit scleral lens on the ptotic eye, none of the above. I'll put my comment in the chat box.
While those are coming in, Ashley, a question came in a little bit ago. Who provides the impression materials when you're doing that scleral?
A great question. So when you get certified, which is what you have to do for the impression-based lens, you get certified to be a provider for this, and then they provide you with all the impression material.
Thank you very much.
Of course.
All right, we have the answers rolling in here, and I think we have a good start here. Give it a minute. Display it out. We have 14% going monitor. The winner is refer for surgical ptosis repair with fit with a scleral dentotic eye, 15%. And then Joe, I'm not sure if there's any answers rolling in, but we have a few people saying none. I'll put a comment in the chat box.
It is the same one. They're talking about Upneek.
Mm-hmm. So this beautiful patient, I thought it was, I actually didn't agree with the fact that she had a prominent ptosis. I mean, the way she described it, it was as if the lid was halfway down the visual axis. She was just so distraught by the way she looks in pictures and those things, but you just have to meet patients where they're at. She is the ideal candidate for Upneek. So the top picture is without Upneek, the bottom picture is with Upneek, only in the ptotic eye, and we're getting a pretty good improvement, and she's very happy with using it as needed. So what exactly is Upneek? So it was FDA approved in May of 2020. It's oxymetazoline hydrochloride. This is a alpha-1 and partial alpha-2 adrenergic agonist that causes the Mueller's muscle to contract. So I had to dig deep. I was like, the Mueller's muscle. Okay, I remember the levator muscle. So the levator muscle is a voluntary muscle. Mueller's muscle is an involuntary muscle that is controlled by the sympathetic nervous system. So upneek is a sympathomimetic. So it will cause Mueller's muscle to contract. It does not cause a dramatic contraction. It doesn't cause a dramatic lid lift, but just enough for these patients, like my patient, that wants a little improvement in the way their ptosis looks. It's the only FDA-approved prescription eye drop for acquired ptosis. Average upper eyelid lift with upneek in clinical trials was 1 millimeter, but for some patients, they get as much as 3.5 millimeters, which would be a lot. How is it prescribed? 1 drop each day. It's exclusively filled at RVL Pharmaceuticals in New Jersey. There is no insurance coverage. So for those of you that hate prior authorizations as much as I do, there are none. So you just prescribe it and let them take care of it from there. It's delivered directly to the patient's house. So it's kind of one of those fancy, concierge sort of drugs that patients, they love it if they can afford it. So the cost is about $160 for a 30-day supply. I actually looked it up today and I was seeing as upwards of $250. So I know it can vary from place to place, state to state. I don't know, but somewhere between $160 to $200 is what these patients would pay for a 30-day supply. Most of my patients that use this drop, which is a lot of them, they don't use it every day. They typically use it when they know they're going to be on camera, when they're taking family pictures, something like that. So I don't think they're using a full 30-day supply in 30 days. How long does it take to work? About 15 minutes, but it reaches peak effect at the 2-hour post-installation mark. It's a really great drop that can be used in office. So you can drop the patient, go do something else, and then come back and watch the patient be so excited about how much better their lids work. A lot of my patients aren't using it specifically for ptosis. They're just using it to open their eyes and to get a more wide-eyed look. She's one of the only patients that are using it just for ptosis. Most patients are using it bilateral just to get, a more wide-eyed look. Response typically lasts about 8 hours. So you tell the patient if they're wearing contact lenses to remove their contact lens before putting the upneek in and to wait about 15 minutes. And the same sort of thing for other ophthalmic drops. If they're using other drops, you want to administer them about 15 minutes apart. And then it's only FDA approved for 1 drop per day. This is a very dramatic case. The patient had bilateral ptosis, and then she's getting that close to 3.5 millimeter improvement in the appearance of the lids. So again, this I wouldn't say is normal. This is a very dramatic improvement. There are no real true contraindications. I mean, it is a sympathomimetic, so we do have to be careful of patients that have cardiovascular disease, patients that have cerebral or coronary insufficiency, patients that have primary angle closure or narrow angles, and then patients that have hyperthyroidism, they may be more sensitive to adrenergic stimulation. So we do need to be careful. There are no true contraindications, but it's our job to doctor and to make sure that we're not prescribing something that could be detrimental to the patient, especially for a cosmetic reason. All right, so that is all about Vuity. Any questions?
That was all about upneek.
Upneek. I gave away the next one. Dang it. Yes, thank you. It's late. All about upneek.
That was upneek. All right.
All right, so I guess we're moving on to the next one. So this one is the problematic presbyopia. So a 55-year-old white female, she's a dentist. She actually works down the hall from my office. So I run into her all the time in the hall on the way into the office. When she does my teeth cleaning, she is constantly telling me about how she hates her contacts. She is a -2 in one eye, -250 in the other eye, and she sees so much better up close without her contact lenses. And I've tried year after year to explain to her it's because she has the perfect amount of nearsightedness to see up close, to see her work. The minute she puts on her multifocals, she's annoyed. She can see up close, but she sees, again, so much better without her contact lenses on. I get that, but she just does not. So my treatment of choice for this particular patient was Vuity. We've tried every type of bifocal. We've tried monovision, which wouldn't be ideal for a dentist that needs, depth perception. We've tried just allowing her to be without contacts in her office, just to work. Her office is really small, so she wouldn't be terribly blurry at distance, but again, that bothered her too. She wanted the best of both worlds. She wanted her 35-year-old eyes again. So I tried Vuity on top of her contact lenses. So her patient continued with her habitual contact lenses. She adds 1 drop of Vuity each morning before putting in her contact lenses, or she removes her contact lenses to put the drop in. And she reports having remarkably better vision at near for 5 to 6 hours. And she's happy with that. This has been a years-long challenge to get her to a place that she's happy. And she's one of the few patients that I have that really enjoys using Vuity. So what exactly is it? We all know about this drop. It was FDA approved in October of 2021. It is 1.25% pilocarpine. So pilocarpine mimics acetylcholine. It's a neurotransmitter that activates the muscarinic receptors on the ciliary muscle of the eye. So it is essentially a miotic. It also will activate, it will cause the iris sphincter to constrict. So that's how we're getting some meiosis. And then the ciliary muscle, it contracts it, which allows the patient to kind of activate a little bit more accommodation. So it creates a pinhole effect by making the pupil smaller, giving the patient some sort of extended depth of focus. So that is essentially how pilocarpine works. Again, whether you love it or hate it, there are certainly indications that work for certain patients, but it wasn't what they intended it to be, a replacement for near correction of all kinds. So again, is what it is. How is it prescribed? 1 drop in each eye daily. It takes effect in about 15 minutes, and it usually lasts up to 6 hours. The cost of it is somewhere from $90 to $100 for a 30-day supply. Again, I think that can vary, but that's approximately what it is. And the same thing as before. So the patient must remove their contact lenses before putting the drop in. And then they want to separate other ophthalmic drops by 15 minutes. But the FDA has now approved this drop for twice-a-day dosing back in March of last year. And what that does is it allows the patient a little bit of flexibility on when and how they put the drop in. So typically that second dose is recommended to be put in 3 to 6 hours after the first drop, and that can extend the treatment for a total of 9 hours. So again, it's a little bit cumbersome, but patients that love it and use it the way that they want, they like that they have a little bit of control over their near vision. Ideal candidates are those patients that are early presbyopes with minimal to no refractive error, presbyopes who prefer to just wear distance correction, people that want to enhance their near vision, not replace their near vision, like not improve it to what it was 20 years ago, and presbyopes who don't have precise vision needs. This has really been, that last bullet point is the category that I found that it's helped the most. Patients that really don't have to be on a computer, don't have to do a lot of reading. They just want to see a little bit better up close. They're not very picky at all. They're just looking for a little bit of improvement. Not ideal candidates at all are advanced presbyopes, dense cataract patients, patients that want to replace their near correction, and then super picky presbyopes like my patient. I really didn't think it was going to work for her, but she loves it. Some of the side effects, patients definitely report this: a headache, brow ache. They get this dimming or darkening of their vision, kind of like tunnel vision, and then their eyes could potentially get red. There are some contraindications, some things that we certainly should know about. Because this lens is contracting the ciliary muscle, it is exerting traction on the vitreous body. So we could be potentially putting patients at risk for retinal detachment. So patients that have high myopia, patients that already have had, they have risk factors for retinal detachments like lattice degeneration, retinal holes, retinal tears. We really should be cautious with these particular patients. And then patients that have inflammatory diseases like uveitis, I had to think about this because those patients sometimes have posterior synechiae. So if we are causing the pupil to constrict, we could be making that synechiae worse. We could be causing scarring to the iris. So we definitely want to be careful with those particular patients as well. We all probably know that there have been reports of retinal detachments with Vuity. And then in 2023, there were 3 cases of RDs and 4 cases of retinal tears reported to the FDA with patients that were using Vuity. We don't have an update from 2024 just yet. But despite all of that, there is an interest in these presbyopia correcting drops. Many patients want something that will just kind of magically defy aging, that will magically allow them to not have to wear their correction anymore. There's lots of drops on the market. The one that I want to bring to everyone's attention, or lots of drops that are coming to market, is the one from Lens Therapeutics. It's the only one that is a pupil selective myotic. So it only works on the iris sphincter. It does not work on the ciliary muscle. So there really shouldn't be any side effects like a headache or a brow ache or any risk of a retinal detachment. If this drop comes to market, it could be revolutionary. Who knows? We thought Vuity would be, but the fact that it is only pupil selective could be a game changer.
You know, when you talk about the issue from retinal detachment, Ashley, and Greg, correct me if I'm wrong, if I'm misquoting this, but I think a paper came out very recently that looked at the relative risk. And in the age-matched controls, I think the risk of retinal detachment was 0.25%, and the risk people using this medication was 0.75%. So yeah, it was statistically significant, but it was actually relatively rare or uncommon. I'm not sure if I'm misquoting that or not. And the question,
you're
a couple
accurate on
questions.
that, Joe.
Okay. What about distance visual acuity with multifocal lens after using Vuity?
Yeah, so there is obviously a chance that that was going to decrease her distance visual acuity, but she is so hyper focused on her near vision being better that it wasn't an impact on this particular patient, but it definitely can reduce distance vision. That's for sure a possibility.
Yeah, I just met with the MSL for a cyclidine, the lens product. I think the PDUFA date is like August of 2025. I'm really curious to see how this all works out. You know, comment is, you know, Joe and I are old enough when we were at PCO that we were using 1% to 6% pilocarpine as our glaucoma medication.
Right.
You know, so you know, this retinal detachment thing, yes, I guess we got to all be careful with it, but I agree with you. This is not working on the ciliary body. So all this kind of stresses and myopic shift and just doing that pupil. And I was joking with the MSL, the medical science liaison, as I was chatting with them. And Chuck Wormington back at the PCO used to beat into our heads like I used to thought this was going to be needed someday. And 32 years later, it came to me that it was useful, that the optimal size of a pinhole was 1.8 millimeters. I thought like that was supposed to be like it was beaten to our heads, right? The optimal size of a pinhole, 1.8 millimeters. And that's exactly about where a cyclidine gets this pupil to be while sparing that ciliary body. So just increasing that depth of focus. I think we might have one that's out there. If it is as good as the papers are showing in these phase 2 and 3 studies, I think we're going to have something that might be a little bit better than Vuity. So.
I 100% agree. So kind of just segueing into what Greg was saying. So the sweet spot is about 30% meiosis from the patient's natural pupil size. And what we're wanting is 2 millimeters or less to achieve clinically impactful improvement in near vision. So that's kind of the benchmark that everyone's trying to achieve. So we'll see. The future is exciting. So we have 3 more cases, I think, but we're only going to get through one more. So this is one of my favorites. So this will be a great way to end this talk tonight. So case number 6 is the astigmatic athlete. So this child is 8 years old, African-American female. She plays every sport there is. Her maternal grandfather has keratoconus. She has no signs of keratoconus, but she does have high SIL. She's never worn contact lenses of any kind, has been wearing glasses since 5, but she's begged her parents to wear contacts. Because she's so athletic, she just wants to wear contacts, and that's completely reasonable. Her parents not only are interested in putting her in contacts, but they want myopia management. Both of them are high myopes, and they just want better for their child, which I love that type of parent that, you know, only wants what's best for their child, and they want better for their child than what they had. So this is her manifest refraction. Remember, she is only 8. So minus 450, minus 3.25, minus 4, minus 3.25 with the rule of astigmatism. No keratoconus. We can see her really basic topographies here, just very, very, very significant with the rule of astigmatism, but her Ks are pretty normal. I'm not worried about keratoconus for her right now, but she's, again, only 8, so she's on my radar for the future. So polling question. So remember, this parent wants myopia management. What do we want to do for this particular patient? We have lots of options.
All right. So what is your treatment choice for this patient? Atropine, ortho-K, soft toric multifocal, spectacles, combo, none of the above. I'll put my comment in the chat box. Atropine, ortho-K, soft toric multifocal, spectacles, combo, comment in the chat box. And they are rolling in.
Rolling in.
I was in Poland recently lecturing about 3 weeks ago now, 3 or 4. It was right after the academy. So right before Thanksgiving, I guess. We'll chat about a little bit of a different technology once you get through this part that hopefully will make it to the United States someday.
I hope so. We'll take all we can get.
Going
All
back
right.
to the last topic, somebody made a comment, practiced 40 years, never saw a retinal detachment from a myotic. I guess I can say the same thing because when Greg and I used to prescribe pilocarpine, we never saw the retina again. In fact, before we prescribed it, we had a going away party for the patient's retina.
How about those pupils on 6%, Joe? Remember that? Jeez. We don't want you to use your Pilo for the next 3 months so we can do a DFE on you.
Yeah,
So.
we can look at the retina.
All right, let me show the answers here. We have 9% going with atropine. Your winner by barely is ortho-K. Then we have a soft toric multifocal, 3% less at 27. The ortho-K was 30%. Spectacles is 4, and then combo is 27.
I like that. Okay, so my treatment of choice, which is, you're going to be shocked, I think, is a synergized ID extended depth of focus. I'll talk about why I chose that, but let's talk about why you chose what you chose. So atropine, I love atropine. We all know the LAMP trial tells us that 0.05% is the most effective dosing of atropine. But remember, this child really, really, really wants to wear contact lenses. So we could control myopia with the atropine, have her wear single vision contact lenses, definitely feasible. But I was looking not for a combination. I really wanted to do a single modality for her. Orthokeratology, absolutely. We could do this, but that SIL is high. She had 3 diopters of SIL. Most orthokeratology designs are approved up to 1.5 diopters of SIL. Some of you sounds like pretty cavalier and you want to take on this fairly high myope, very high SIL case. And you could, if you have the technology to design lenses for a patient like this, that is a very appropriate option. Soft toric multifocal center distance could also be good. She may have a little instability with her vision because of the prism ballast design. Maybe not. That this is a totally reasonable option for her. And spectacles, absolutely not. Least effective myopia management strategy. She wants to be free from spectacles. She's already in them. The reason she came to me is to get out of them. So you may be thinking, why would you choose a hybrid design for an 8-year-old? Well, why? What? It's definitely a risk for sure. But her parents were willing to help. This child was more motivated than I've ever seen a child to wear contact lenses. And kids can do hard things. They really can. If we put them up to it, we set the standard, they will rise to the occasion. So what do I like about hybrid lenses, especially for this patient? So hybrid, we were talking about piggybacks way back earlier in this talk, but a hybrid lens is actually a very fancy hybrid piggyback. So the center of the lens is the GP material. So that's going to provide high quality optics for the patient. And it creates a tear layer that will likely neutralize all the corneal astigmatism if you choose the right patient. And I'll tell you what the right patient would be. And this would allow the patient to have very stable vision. So she can blink, she can move around, and we don't have to worry about that lens decentering or giving giving her blurry vision. The side-high skirt allows her to have nice comfort. And then we can personalize this lens. The Synergized ID lens is the top of the top hybrid lens available to us now. And we can customize pretty much every aspect of this lens to give her the best vision and the best comfort. So you make this lens with a few parameters: the patient's Ks, her HVID, and her prescription. So this is just a reminder of those things. If you remember, HVID is white to white measurement. So it is basically the width of the cornea. The average horizontal visible iris diameter is anywhere from 11.6 to 12.0. We can get HVID with a slit lamp reticle. We can make an optic section, turn it horizontal, and just measure it with our ruler up at the top. But you can also use HVID rulers. You could use your topographer. I like to use the HVID for my topographer. And then if you remember, you can also use your loop. The loop has a little scale on it. You can put it up to the patient and just measure their HVID. What I do want to make sure everyone realizes is that this is absolutely an off-label use of this lens for myopia management. Just because it's off-label doesn't mean you should be afraid of it. We do tons of things off-label. The key here is that this is a center distance design, which we know center distance designs work really well for myopia management. This is an extended depth of focus lens. So it essentially means that there is center distance in the middle, and then we're adding power as the lens goes out to the periphery. But this is going to give the patient really good vision and a myopia control effect at the same time. There's only one and only FDA-approved myopia control option, and that's the MiSight 1-Day. This would not work for this particular patient because she has so much SIL, but I felt like I needed to at least talk about this lens. It slowed myopia progression by 59% and axial elongation by 52% on average over a 3-year period in their very great pivotal 7-year clinical trial. It was a great trial that was done several years ago. Approximately 25% of the patients progressed only a quarter diopter or less over 6 years, and there was no significant rebound effect or adverse events during the study. This lens is FDA approved for patients 8 to 12 years old at the initiation of treatment, and it's available in a -0.5 to -7. So this is how this lens is, the hybrid, going back to the hybrid, this is how we design this lens. You do it completely empirically. You use this online calculator and you just go through the prompts. So you choose Synergized ID multifocal. That's what you want to fit for this patient. You put in the patient's case, you put in the patient's HVID, their sphere, their cylinder. For this patient, we're fitting her in a presbyopic lens because we're using it off-label for myopia control. So I'm giving her the highest add of a 250. You can choose whether to use an enhanced profile, which makes the lens a little bit thicker. I opted for yes. And then I did not want to add HydroPeg because it makes the lens a little slimy, a little bit difficult to insert and remove. What I love about this lens is that it automatically spits out the parameters and it tells you how much residual astigmatism you'll have. A half a diopter is hardly nothing. So what that means is that the refractive SIL and the corneal SIL pretty much match, and that creates an ideal patient for this lens. Let's say that calculated residual astigmatism came out to be a diopter and a half, 2 diopters. It wouldn't even allow you to order the lens. So 75 diopter or 0.75 diopters of SIL or less is ideal for the residual astigmatism. Again, half a diopter, totally fine. So these are the lens parameters that we dispense. The patient saw really great out of the lens. The lens fit her beautifully, just like this. We have nice alignment in just maybe a little bit of clearance here. We really want central alignment, but the fluorescein pattern is a little dense here. But overall, this is pretty aligned with the nice skirt sitting on the conjunctiva and the sclera. But the patient had a really, really hard time putting this lens in. This is a big girl lens for a little child. So I knew we were going to have trouble, and it took her several tries. So we tried the tripod method, holding it with her 3 fingers, and then the plunger method. She ultimately liked using the tripod method. And the way we were able to get this lens on is her parents helped her hold her lids, and she was able to get the lens onto her eye eventually. Now, many years later, she's able to do it completely by herself, but it took a few tries. Again, the follow-up visit, patient was seeing really great, hardly any over-refraction on the very first lens. So the empirical calculator works beautifully. She's able to wear this lens for all waking hours. She can wear cute sunglasses. She can be athletic. And I followed this patient for over 3 years now, and she has barely progressed in her myopia, and her axial lengthening is normalized. It was like going up to, it was increasing by about 0.4 every year. Now we're getting about 0.2-ish millimeters in axial lengthening every year, which is about what we would expect for her age. So that is that. Oh, I wanted to just make a comment that fitting kids in contact lenses can be tricky. Fitting them in specialty lenses is even trickier. But if you have the right patient, the right scenario, the right patient support, you really can fit patients in anything. The sky is the limit. So don't limit yourself by what you think the patient can handle. Just prescribe what you think is the best option for them. All right, that's it.
Joe, are there any questions? And while you're looking, I'm going to make a comment. If there was a Hoya lens and there was a Essilor lens, and I remember the Essilor lens called the Stellest, Stellest. It's not available in the United States. It has something to do with the wording that they say treatment and it can't be treatment, and it's all caught up in the FDA. But for those that are out there, take a look at the lens. It's kind of cool. It's all these small little lenses taking care of that hyperopic blur that's out there that is thought to create that eye to want to keep continuing to elongate. So hopefully that lens will make it here, because they found it really to be, out of everything that we talked about, atropine and contact lenses, that's really one of the best ways of treating. But we don't have options. We don't have access to it. So.
Now we
So
are
I'm going to
caught up in
have you
questions.
stop sharing your screen if you would.
Okay.
And then Joe, what was about the questions?
No, we are caught up. We're done.
Okay. So everyone, before we wrap up here, if you look right here on your screen, you'll see that little red dot. You can start doing that survey question. I know this says nightmares and nonsense, but right there it is. And we did hear unique strategies for managing common anterior and refractive conditions. Ashley, Joe and I, what we like to do is bring clinicians on that actually do the things rather than just talk about it and teach it. And it's quite obviously that from the last hour and 40 minutes of your insights that you're doing this day in and day out and able to share it to our audience. So I want to thank you for helping us wrap up 2024 in a very high successful way, and with this synchronous virtual course. Joe, any questions and final comments before we wrap up the webinar?
No other questions. We've covered, I think, pretty much all of them, but I agree. Actually, the facility that you speak with on this topic tells us that you're really clearly a clinical expert. We do appreciate, and I'm sure the audience really appreciates you sharing your insight and clinical experience with us. So this was a very nice way for us to end our 2024 season. So thank you very much.
Thank you. Happy holidays, everyone.
Yes. So with that said, that will end our education for this. We do have some housekeeping coming up. And again, this ends the synchronous virtual course, Unique Strategies for Managing Common Anterior and Refractive Conditions.